get us into that practice session.
Okay, Let's talk about health, a community conversation. Today's conversation is our 7th in our monthly series. I'm Donna Jacobs, and I will be your moderator today. I'm Senior Vice President at the University of Maryland Medical System. We began this monthly conversation on health in June with the goal of increasing awareness and understanding about important and specific health topics. We had a goal to provide health information, which admittedly can often be very confusing, in a clear, concise, and digestible format to the communities that we serve. We also sought to improve health information and provider and patient communication, and through this dialogue to help people become more aware of how they can take care of their health and promote their well-being. We host these community conversations at noon to make them more accessible to as many as possible and to give many an opportunity to participate in this kind of dialogue. Today's conversation is about lung disease, and I'm very pleased that we have Dr. Peter Olivieri here to lead our conversation. He's a member of the Pulmonary and Critical Care Medicine team at the University of Maryland, Baltimore, Washington Medical Center. He's a graduate of Thomas & Jefferson Medical School in Philadelphia, and he is no stranger to the University of Maryland Medical System, having completed his internal medicine residency, his chief residency, and pulmonary and critical care fellowship at the University of Maryland Medical Center. He's the lead physician at the Baltimore Washington Medical Center's outpatient clinic, which specializes in the evaluation and treatment of lung nodules and lung masses. Before I turn this over to Dr. Olivieri, please let me let you all know that you can feel free to use the Q&A box on your screen at any time to type in questions that you might have. And Dr. Olivieri will be happy to answer those as we go along and to answer as many as possible before we conclude. Should there be a high number of questions that we don't get to, Dr. Olivieri has agreed to provide answers to those, and we'll be able to post that together with this conversation, the entire series, which you can view later, and more on that. As well, online, you will be able to see the slides again, should you choose, and I'll give that information at the end of this session. So, Dr. Olivieri, please.
Thank you so much for having me today. It's really a pleasure to join, and good afternoon. So we're going to be discussing lung disease today, and we're going to be focusing on a particular disease called COPD. But before I get into that, I just wanted to let everyone know about Ask Me 3. So Ask Me 3 is a program that is designed and encourages patients to ask 3 specific questions of their healthcare providers in an effort to better understand their medical conditions and work in a partnership with their providers to work toward getting healthy and staying healthy. And the 3 basic questions are, number 1, what is my main problem? Number 2, what do I need to do? And number 3, why is it important for me to do this? And we're going to be integrating that into our discussion today. So as I mentioned, we're going to be focusing on a disease, a lung disease called COPD. This stands for chronic obstructive pulmonary disease. And these are some of the important questions that we're going to be touching on today during our discussion. What is it? What causes it? How do I know if I have it? And how is it treated? We're first going to talk about what COPD is. And in order to do that, we need to understand that when I think about COPD, I really think about 3 different components. So it is a chronic lung disease. And by that, I mean it's a condition that when patients have it, they tend to live with it for a prolonged period of time. It's not just a acute thing that comes and then goes away. The symptoms are similar to several other lung conditions, which is an important point. And these often include cough, trouble breathing or shortness of breath, and the chronic production of sputum or mucus when they cough. It's important to know that this is largely a disease of patients who either are current or prior smokers. And it's estimated that about 90% of cases of COPD are attributable to cigarette smoking. There are other risk factors for the condition as well, including some occupational exposures. For instance, patients that are coal miners and spend a lot of time inhaling particles that may do damage to the lungs while they're mining. And in other countries where it is a common practice to burn material indoors for heating their home and cooking, this is also a risk factor. But in the United States, the vast majority of cases are related directly to smoking. So we talked about the symptoms and the risk factors. Really, the third piece, which is one that I definitely want to focus on today, is that it's very important that patients get what's called a pulmonary function test to confirm the diagnosis. And this is a non-invasive test that we'll talk more about that can be done in an outpatient office, and it's the test of choice to confirm the diagnosis of COPD. Talking a little bit more about what COPD is, I wanted to touch a little bit on what it actually looks like in the lung. So many people have heard of the term emphysema. What emphysema is basically lung damage that's characterized by holes in the lungs. And this is part of COPD. It is a feature of COPD. Most patients with COPD have emphysema, but not all. And you can see from this picture that the upper part of the lung is predominantly affected, and you see these holes in the top part of the lung. And these are, again, due to the destruction of lung tissue over time by the inhalation of smoke or other particles that the patient may be exposed to. This is a real CAT scan, which is a type of picture of the chest that shows the same thing. And you can see the black holes, especially at the tops of the lungs, and this represents the emphysema in a patient with COPD. Another feature of COPD is something called chronic bronchitis. Once again, this is a feature of COPD that many patients have. In fact, most patients with COPD have both emphysema and chronic bronchitis. Chronic bronchitis affects the tubes in the lungs. The lungs have a series of tubes, which are the airways, that move air in and out. And these can become chronically irritated and inflamed, and this is what is known as chronic bronchitis. So you can see in the picture that the airway in cross-section on the right-hand side is more thickened, and this is what it might look like in a patient with chronic bronchitis. This chronic irritation and inflammation is part of why many patients with COPD have a nagging cough and often have a lot of mucus and sputum production. On a global scale, COPD is very important, and in 2016, the World Health Organization determined that it was the third leading cause of death in the world, just behind heart disease and stroke. And it was actually a more common cause of death than diabetes, for instance, and dementia, as well as lung cancer. We already touched on the causes of COPD. Just wanted to reemphasize that it is far and away in the United States, it is primarily a disease of patients who have been exposed to smoking at some point. And part of why this is important is that if you're being told that you have COPD but you've never been a smoker, the diagnosis should be questioned. So this brings us into our first Ask Me 3 question. The first question is, and this is a case example, I used to smoke but quit a few years ago. I have noticed that for the past year, I have been getting more out of breath when I do yard work and cleaning. Do I have COPD? And this would be a very good, and this is a very common question that comes up in practice. Oftentimes when patients have a history of smoking and they present with trouble breathing, it is assumed that they have COPD. But it's important to understand that there are many other conditions that can also cause these same symptoms. So the answer is there are many causes of shortness of breath, including heart and lung diseases, such as COPD. and specific testing should be done to determine the cause of the symptoms. Part 2, what do I need to do? Part of the answer is to get a pulmonary function test. Again, this is a non-invasive breathing test that can determine how your lungs are functioning, and it can determine whether or not you have COPD. Important to know that COPD cannot be diagnosed without pulmonary function tests. So if you're being told that you have COPD and you've never had pulmonary function tests, you should definitely inquire about getting pulmonary function tests. Why is it important for me to do this? Because COPD is a condition that can be managed, and it's very important to know whether or not you have the condition. If you have symptoms and the pulmonary function tests determine that you don't have COPD, that is important as well because it can help guide us toward other tests to look for other conditions that can cause those same symptoms. So we talked a little bit in the beginning about what is COPD. Now we're talking a little bit about how do I know if I have COPD, and I've already alluded to this multiple times. It really centers on a test called the pulmonary function test, or PFT, as you may hear it referred to. And if we could just advance to the next slide for a moment, we'll come back to this one. This is just a picture that shows what a pulmonary function test looks like. Again, this is a non-invasive test that is often done in an outpatient clinical office. It can be done in a pulmonology office, such as where I work, and some primary physicians also have the equipment to do this. And it's a series of breathing maneuvers where the patient is asked to breathe in and out through a machine like this, and this helps to measure their lung function. It takes about 30 to 45 minutes, and this is what a PFT is. So if we could just return to the prior slide. Our next Ask Me 3 question is, I was diagnosed with COPD a few years ago, but have never gotten a flu shot before. Should I get it this year because of the pandemic? The answer is getting a flu vaccine is important every year, especially for patients with lung diseases like COPD. The reason for this is that patients with underlying lung diseases, including COPD, are at risk for having a much more severe disease if they get a respiratory infection such as the flu. Of course, the flu vaccine does not protect against COVID-19, so in that sense, it's important to get the flu shot every year, not just during the pandemic. There is, just as a quick sidebar, obviously there are some vaccines that are now finally becoming available, actually just this week, and there will be a couple of talks too, in fact, that are coming up in the near future within our system, one as part of this series and another being given by a member of the UMMS system, and those will be referenced later in the talk, and those will address the COVID-19 vaccine specifically for those that are interested. Moving on to the next question, what do I need to do? You should get vaccinated against both influenza as well as pneumonia and encourage your family and those around you to do the same. The flu vaccine is an annual shot, and there are also 2 different vaccines for pneumonia that patients with COPD are eligible for, and they should get those as well to reduce their chances of getting pneumonia. Why is it important for me to do this? Patients with COPD can have a more severe, sometimes life-threatening course with respiratory infections such as the flu or pneumonia, and vaccines represent a way to potentially prevent these things. So I just wanted to touch briefly on something called an exacerbation. So COPD, as I mentioned, is a chronic condition, which means it's something that patients live with for often many years. However, superimposed on this daily problem, there are intermittent flare-ups which can occur that some patients with COPD can get. And when this happens, the patient will temporarily have worsening of their symptoms. So the cough and the trouble breathing and the phlegm that they normally get for a period of time will become worse. And this is called an exacerbation or a flare-up. It is often triggered by an infection, which is often a viral infection. And many times patients will have to see their physician either in the office, or if it's a more severe exacerbation, they may go to the emergency department and possibly even be admitted to the hospital. So moving on to the final part of our discussion, we're going to talk a little bit about the treatment of COPD. And I'd like to break this up into how we treat an exacerbation or flare-up and contrast this with the routine day-to-day care of a patient with COPD who is not having a flare-up. Exacerbations, as I mentioned, often require a visit either to a physician's office or to the hospital. And during these times, patients can feel quite ill and require treatment either inside or outside the hospital with a variety of medications and support measures. These include inhalers, such as the one in this picture, a medicine called albuterol, which can help patients breathe, or a nebulizer treatment, which is shown in the lower left-hand corner. Often patients have to be treated with steroids. You may be familiar with a medication called prednisone, which is one of the most common ones that we use. This helps to calm down the inflammation in the airways. Sometimes antibiotics are used as well. And for those patients that require admission to the hospital, they may require support of their breathing, either with oxygen, a mask, or in the most severe instances, if they're in the intensive care unit, they may even require a breathing tube for life support. So that's the overview of how we manage patients who are having an exacerbation. Outside of an exacerbation, there are many different components to the treatment of COPD in the long term. And really one of the cornerstones is smoking cessation, or trying to work with our patients to help them to quit smoking. Because we know that this is often the underlying cause of COPD, and the sooner they quit, the sooner they can stop losing lung function and can slow down the progression of their disease and feel better. Many of these other interventions are, if you could just go back for one moment, used for specific subsets of patients with COPD. Most patients are on inhalers. All patients should receive appropriate vaccination, as we already addressed. A subset of patients who have low oxygen levels may require oxygen at home. And most of these patients, depending on how much they've smoked, they may be eligible for an annual CAT scan to screen for lung cancer, almost similarly to how mammograms and colonoscopies are used to screen for cancer. And smaller subsets of patients with COPD may be eligible for other interventions such as surgery or even lung transplant in the most severe cases. And pulmonary rehabilitation is a supervised exercise program that can be very helpful for patients in improving their quality of life. Just to focus in briefly on smoking cessation, part of why this is so important is that it does slow down the progression of COPD. So by quitting smoking, patients with COPD can preserve the lung function that they have to preserve their quality of life. And there are also several other benefits that really are unrelated to the lungs that are associated with quitting smoking, including reducing the chance of dying of a heart attack or stroke, and also reducing the chance of getting multiple different cancers, including lung cancer. I have smoked for many years and have been diagnosed with COPD. Is there really a benefit to quitting smoking now that I already have the disease? And the answer is absolutely, as we've just gone over. Although COPD is not reversible, continued smoking causes the disease to worsen and leads to many other preventable health problems. Quitting smoking will slow down the progression and prevent these other issues. What do I need to do? Talk to your doctor about quitting smoking. There are many resources available to help you quit, including medicines and support groups. Why is it important for me to do this? Quitting smoking now can prevent COPD from developing or worsening. It can also reduce the risk of dying of a heart attack or stroke or getting cancer. And this is a list of some helpful resources online that can provide some more information for patients or family members regarding COPD. And we're happy to take any questions you may have.
Dr. Olivieri, thank you so much. I have learned so much from all of these sessions, but most especially today, and I want to thank you for your pace and clear explanations on all of that. We do have a few questions that have come in, And the first one is, there's a lot of information, and I may have missed some of this, but can you just once again go over the causes of COPD, since you referred to it repeatedly in your talk?
Absolutely. So in the United States, it's estimated that about 90% of cases of COPD are due to smoking. So most commonly, cigarette smoking. In a much smaller proportion of cases, patients who are not smokers and have never been smokers may develop COPD from long-term inhalation of irritants. And the example that I provided was in the mining community, among those that have worked in coal mines for a long period of time. If they've breathed in a lot of the coal dust, over time this can lead to lung damage. In the developing world, there is also a population that can develop COPD from breathing in smoke from indoor fires. And these are countries where biomass is burned inside the home for heating and cooking, and women and children are disproportionately affected, but this is not really something we see much in the United States. So the bottom line is it's really a condition associated with cigarette smoking in the U.S. for the most part, and if patients have never been smokers, we should really question the diagnosis of COPD and look for other things.
That's excellent. Let me just remind or tell for the first time those who may have not been here at the top of the session that you can type your questions in the box that says Q&A, and we'll try to get to as many of those as is possible. And they're coming in now, Dr. Olivieri. So the next question says, I tested positive for COVID-19 and have been struggling with my breathing. I now have oxygen at home, and I'm not sure when I need to use it.
Yeah, this is an issue that we're seeing more and more. In fact, we have a clinic that's dedicated to the care of patients with COVID-19 who have survived after a stay in our intensive care unit. And it's something that I think we're going to learn a lot more about in the coming years. Right now, we're really just starting to see that many of our patients who are able to come through the initial infection are left with some ongoing symptoms and in some cases, the need for oxygen. The answer to your question is we generally recommend supplemental oxygen for patients when the oxygen saturation, and that's the number that comes from the test where you put a sensor on your finger that measures your oxygen level in your blood. When that number is below 88%, when it's below 88%, we recommend oxygen. And in some cases, when you're just sitting there resting, your oxygen level may be in the high 90s, which is great, but you may notice that the oxygen level falls when you are exerting yourself, whether that's walking or exercising. And in those cases, sometimes patients need to use the supplemental oxygen only when they're doing those activities. So if you're not sure what your oxygen saturation levels are, it can be helpful to obtain what's called a pulse oximeter, which is a little device that you can buy usually at the pharmacy. And this is something you can also talk to your physician about. And it can be quite helpful to monitor your oxygen levels at home, both at rest as well as with exertion. And your doctor can also order a specific test to formally check these levels in the office setting if you don't have the means to do that.
Okay. The next question is, well, there's a hi for you, but does the damage of the alveoli, I hope I'm saying that right, repair itself if someone quits smoking?
That's a great question. The answer is kind of complicated. The short answer is probably yes, because COPD is really only one piece of the puzzle in terms of smoking-related lung disease. So when patients smoke, there are many different aspects to the damage and the irritation that the smoke causes. And some of that is quite reversible. So when you quit smoking, the inflammation and the irritation will go away, including in the alveoli, very quickly, and will continue to get better the longer you stay away from smoking. In terms of the COPD itself, what we know is that once you have COPD, that itself is usually not reversible, meaning if you have COPD confirmed by pulmonary function tests, typically your lung function will not improve significantly by quitting smoking, but what will happen is when you quit, the continued loss of lung function will slow down or stop. And this is very important because studies have been done where patients who continue to smoke are compared to patients who quit, and those who continue to smoke continue to lose lung function much more quickly, and those that quit can slow down the loss of lung function and preserve a quality of life, preserve how they feel, and preserve the things that they're able to do, which is extremely important for patients.
Alveoli. Okay, I got it. All right, and here's a question. I think the answer is in exacerbation. It says, can virus cause COPD?
Right. So viruses are thought to be the most common cause of flare-ups or exacerbations of COPD. That's exactly right. So if you have COPD and then you get a viral respiratory infection, even if it's just a simple cold virus that might just cause a common cold in somebody without lung disease, that can be enough to cause your COPD to flare up and could lead you to need to see your doctor or maybe even go to the hospital.
There's a general question here. It says, what about secondhand smoke? And I guess that's a broad question on our overall lung health and the causes of as the cause of COPD.
Yeah, that's a hard one to do conclusive studies on. I think if you breathe in enough secondhand smoke over a prolonged period of time, I do think it's possible to develop significant lung damage, including COPD. I would not expect that to happen with just low levels of intermittent secondhand exposure. But for instance, if you're working in a setting like in a bar or restaurant for many years where you're just constantly breathing in smoke, it could certainly affect your lung function over time. I will say, though, that even among those patients, the vast majority of those patients will not develop COPD.
So what about those of us, is it more prevalent for adults than children? What about those of us who grew up as children in households with smoking parents and maybe older sibling as well, when less was understood about the effects of secondhand smoke?
Yeah, all I can really say is that large-scale studies have been done that have looked at groups of patients with COPD with detailed questionnaires, and 90% or so of these patients have had a significant history of smoking themselves. So there probably is a much smaller part of the population that may have, for whatever reason, increased susceptibility that could develop lung disease from the secondhand exposure, but this is a minority. This represents a much smaller proportion of cases. Now, if you have underlying asthma, or some other lung disease, you may be much more susceptible to worsening symptoms, breathing symptoms related to secondhand smoke exposure, which is a separate issue. In that case, you have an underlying condition that's something different from COPD, for instance, asthma, and you may have a very low tolerance for secondhand smoke exposure. That may flare up your breathing very quickly, even with a tiny exposure of just a few minutes.
You mentioned asthma, and the next question is, are asthma and respiratory allergies considered COPD?
That's a really good question. And the short answer is, in its purest form, asthma is a different condition than COPD. But the reality is that the lines can often become quite blurred, and this is a matter of debate even among the pulmonary community as well, because we know that there are overlap cases where patients have features of both asthma and COPD. Asthma, in the purest case, you could think of asthma in a patient who's never been a smoker. So let's say you have a patient who's really never been a smoker, they have no significant smoking history, they may have a history of allergies, and they often develop symptoms of their asthma early in life, and they may be an allergic type person, and they have many of the same symptoms of COPD. They may have shortness of breath, chronic cough, they get treated with inhalers, their pulmonary function tests may even look similar to a patient with COPD. So there are many, many similarities between the two. Where the lines can get blurry is we have many patients who appear to have a history of asthma. So let's say they developed their symptoms as a teenager and they were allergic, they had significant allergies, and they did have asthma, and then they smoked for, let's say, 10 years or 20 years, and then they developed something that looks much more like COPD, but they still have some features of asthma. For instance, they get flared up by exposure to pollen when the seasons change and things like that. So they may have some features of both asthma and COPD. So things can get a little bit confusing, which is why it's always helpful to sort it out with your physician and get the specific testing done with pulmonary function tests and other things sometimes, just to make sure that we're clear on exactly what we're treating.
You keep throwing me the softball to the next question. You said things can get a little confusing. And the next question says, what examples are there of other conditions that are not COPD when chronic issues are present for a non-smoker or a non-minor?
Great question. And this is a huge list of things. When we talk about trouble breathing, I like to break it up into problems related to the heart, problems related to the lungs, and problems that are related to neither the heart nor the lungs. So with the lungs, you have things like COPD. We've also talked about asthma. Those two can be quite indistinguishable regarding the symptoms. But you also have many other lung conditions. So there is a family of scarring diseases of the lung, what we call interstitial lung diseases or scarring of the lungs, as well as many other lung conditions as well, including lung cancer, blood clots in the lungs, what we call pulmonary embolism, and the list really honestly goes on and on. We have entire textbooks about these conditions. Moving over to the heart, there are many different heart conditions that can cause trouble breathing, and some people don't know this. Some people assume that if they feel like their breathing is the problem, they assume that it must be a lung problem. This is not true. Many heart conditions can cause what patients to perceive difficulty with breathing. And sometimes these heart conditions are more dangerous in the short term than the lung conditions. So things like a heart attack or blockages in the arteries can cause shortness of breath. Also, the syndrome of what we call heart failure or congestive heart failure can also cause shortness of breath. And these conditions can be more dangerous in the short term than lung conditions, which is part of why I place so much emphasis with my patients on nailing down the diagnosis first, because once you get an accurate diagnosis, that really dictates management. So if they present to me with trouble breathing, I will not assume that they have COPD. I will get the pulmonary function test. And if those do not demonstrate COPD, then we have to look elsewhere. We may need a CAT scan of the chest. We may need an ultrasound of your heart to look for heart failure, or a stress test to look for blockages in the arteries. So these are just some of the heart and lung conditions, but there are also several other conditions that are unrelated to the heart and lungs, such as low blood counts or anemia. Even low blood counts, what we call anemia, can cause shortness of breath, just to give an example. So there are many, many different things, and shortness of breath is often it at least has the potential to be something dangerous, so it's definitely not something that should be ignored. If you're having trouble breathing, you should definitely seek care and get evaluated so that we can help you sort this out.
You mentioned pulmonary embolism. There's a question here about pulmonary edema. Are they the same thing? And then the question on pulmonary edema says, does that cause COPD?
Okay, so they are not the same thing. So a pulmonary embolism is a blood clot. These blood clots often form in the legs. You may have heard the term deep vein thrombosis, or DVT. And this is a blood clot that forms in the veins, often in the legs, and can then migrate up from the leg into the lung and can clog up important veins in the lung and produce shortness of breath. So that's what a pulmonary embolism is. Pulmonary edema refers to fluid in the lungs. And this is most commonly associated with heart failure or congestive heart failure. So what can happen there is if you have a problem with your heart that causes fluid to back up, it can actually back up from the heart into the lungs. And this is why congestive heart failure causes shortness of breath. The lungs become wet with pulmonary edema as a result of a heart problem. And there are other conditions as well that can also cause pulmonary edema, but this is the most common cause. It's actually related to a heart problem.
Thank you. There are several questions about COPD and whether it worsens with age. I've had a couple of participants say, I haven't smoked in 40 years, but it's worsening. I haven't smoked in 20 years, and it's worsening. Help us with that.
Great observation. So what we know is that everybody loses lung function with age. This is regardless of whether you've ever smoked or not. If you take a healthy young person and if you were to chart their lung function over their entire lifetime, you actually gradually lose a little bit of lung function every single year as we age. The good news is that we're all born with a lot more lung function than we actually need to support us. And this is why in very unfortunate instances where a young person becomes badly injured or if they have some other reason why they need to have an entire lung removed, you can actually have an entire lung removed as a healthy young person and actually still live a very active life, and you may not even have any shortness of breath because we may have twice as much lung function as we actually need. So for those that don't smoke, even though they're losing a little bit of lung function every year, they usually never develop symptoms of shortness of breath, even if they live to be 100 years old, because they have so much lung function, so much extra lung function at birth that they never really burn through that extra lung function. The issue with COPD, part of what makes it so insidious, is that patients often smoke for prolonged periods of time. What they may or may not be aware of is during all those years when they're smoking, they're actually burning through the extra lung function much more quickly than if they weren't smoking. So what this means is if you smoke for, let's say, 20 or 30 years, you may actually not even be short of breath while that's happening, but you're actually losing much more lung function than you realize. What can then happen is even if you quit smoking, you will still continue to lose a little bit of lung function every year, just as we all do. And at some point, you may cross a threshold once you've gotten rid of all the extra lung function and you're just down to the minimal amount of lung function that you actually need to maintain yourself and do your activities. You cross that threshold and then you develop symptoms. So it's a very long-winded way of saying it's actually quite a common phenomenon that patients may smoke for a long time, quit, and then develop symptoms later, 10 or 20 years later. And that is due to the fact that they're continuing to lose a little bit of lung function, and they don't realize that they actually lost most of their lung function years ago when they were smoking.
Thank you. There's a different question. It says, why do I cough? And of course it just moved. Why do I cough? I'm always clearing, and it happens especially at night and sometimes in the day. Can we tell what that is?
Well, there are many different causes of cough. So cough is kind of like shortness of breath. There are many different things that can cause a cough. So the short answer is, unfortunately, based on that information alone, I cannot tell you why you're coughing. Cough is certainly a feature of COPD, but can also be from other things, including asthma. It can be from seasonal allergies among patients that get that postnasal drip that drips in the back of their throat. It can also be from heartburn, believe it or not, or what we call gastroesophageal reflux, or GERD, where acid splashes up from the stomach, and this irritates the back of the throat and causes people to have a cough. Now, if you're having a lot of cough at night, reflux or heartburn would actually be one of the things on the list that could cause that, but it could also be several other things, including some of the conditions that we've mentioned. So that one needs to be sorted out with your physician so that they can ask you a lot of other questions that unfortunately I don't have an opportunity to ask you, and they may need to do some testing as well.
All right, Doctor, yet another perfect segue. One participant has said, my father's having so much difficulty getting answers through various primary care physicians. Is there a list of pulmonologists somewhere that I can look to, or how do I find someone to help sort out these issues?
Yeah, well, the answer is absolutely. We have a practice, and I'm sure, obviously we'd be more than happy to see your loved one. We have several providers in our clinic. Our clinic is located on the campus of Baltimore Washington Medical Center in a building called the Tate Center. And if you go to the BWMC website and you go to the pulmonary section, you can see the list of all of us. And if you give us a call, we'd be more than happy to see your loved one. But obviously, we're not the only practice. There are many different pulmonary practices in the area. So depending on exactly where your loved one lives and what's most convenient, they may have many other options as well. And I don't know if there is a specific link or a website that you want to refer that person to, but
I believe what we can do is when we give the website and people will be able to go up in 48 hours to look for this presentation, we can include the website you mentioned as well.
Excellent.
Do that. All right. There are several questions which we're not going to be able to get to, but maybe we'll just close with I'll group together several that have come in. Several people have said, I'm a COVID-19 survivor and I'm still struggling to breathe. Is there particular advice? Is this something I should expect? Will it go away with time? What do I do? There were several of those.
Yeah. To be honest, this is something that we as a medical community are going to be all learning about together over the next several years. Because we only have experienced this pandemic for less than a year, we haven't really had the opportunity to study patients over time and follow their lung function over time to see to what extent it will improve. I do think that we do expect that the lung function will improve slowly over time, but some patients may be left with ongoing symptoms for quite a while. Some patients may have symptoms perhaps forever. But this is something that honestly is really a matter of research at this point that needs to be further clarified. What I do think would be beneficial, though, would be for you to get linked in with a good primary doctor that you trust, and probably with a pulmonologist if that's available to you, because then we can do pulmonary function tests, we can measure your lung function, we can measure your oxygen levels, and we can monitor that over time so that we can try to give you some clarity on whether or not your lung function is improving or changing over time.
Dr. Olivieri, I really want to thank you for several things, and I'll let the audience know that you've been on the front line treating patients and through this difficult time, and you've got an incredibly busy schedule, yet you took the time today to explain such valuable information in such a cogent, clear, concise, and patient way. Really very grateful to you for both things, for the work you're doing with the COVID patients and now today joining us. We will
an honor and a privilege.
We're very grateful. We will have this session up and available to anyone who'd like to see it again or perhaps see it from the top in about 48 hours, and there's the link there, ums.org/letstalk. I did mention at the top that this is the 7th of our monthly webinar series on community health, and you can see any of the prior sessions that we've held there as well. One on technology and telehealth, the Ask Me 3 analysis that Dr. Olivieri referred to, how to really talk to your physician or your healthcare provider, children's health and safety, men's health, women's health, and diabetes. They're all there for you to view. And as well, coming up, as Dr. Olivieri referred, we have a couple of sessions related to COVID specifically and vaccines. Our next in our series is on COVID vaccines, and that'll be the third Wednesday of January, as they're always on the third Wednesday at noon, totally devoted to the issue of COVID vaccines. And there's so much information that we want to get out to the public. As well, there is a community conversation about vaccines this Friday, and as Dr. Olivieri said, the information is developing as we speak, moment by moment. Community conversation from our CEO, Dr. Mohan Santher, and Dr. David Marcosi, who is the head of our Incident Command. If you've received information about today's webinar by email, you will also be able to receive information about those two items that I mentioned to you by email as well. And again, I want to thank all of you, and we will try to have the additional questions that came up, although topically I think we hit most of it, posted on the site when we post this session in a couple of days, and Dr. Olivieri has agreed to help us provide some answers to those additional items, and you'll be able to see these slides. Thank you, and we hope to see you once again. We'll also post the website that he referred to for BWMC for those of you who are looking for more assistance. Dr. Olivieri, thank you again. So very grateful, and thank you all for joining us today.
Thank you so much.
Ladies and gentlemen, that does conclude today's webinar. You may now disconnect your lines.